Right. So that's Foucault's primary objective of this text, was to see how in the last years of 18th century and 19th century as well, how the medical knowledge, how the field of medicine, the language of medicine itself changed. Right. So before that, in the pre-modern medical science, so we know about the humoral theory, right? Or disease was considered to be something that has something to do with the essence of it, right? So the focus was not on the individual or the individual's body itself, but rather it was on the environment or perhaps the family or the disease, the illness condition, rather than the disease. The illness condition was considered to be a mystery caused by the surroundings, or maybe there's an essence to it. Now, post Descartes and the Cartesian dualism, right? So there is the mind and there is the body. The focus shifts on the body itself. The body becomes an object. So that is where Foucault intervenes. He is looking at both 18th and 19th century to look at how the field of medicine itself has changed. Specifically, the discourse of medicine itself has changed. Now, this idea is not new, right? What we know about Foucault, we all know that he talks about knowledge, right? He talks about the fact that knowledge constructs power and vice versa. So, whatever we talk about, it is a part of an already, it is a part of the structure. So, that is the same kind of idea that this book also takes forth. I'll come back to that later. But for now, he talks about how in the 18th century, so before that, it was the idea of disease was linked to an essence or something else other than the body. Whereas in the 18th century, there was a certain classificatory gaze. That is, the physician looks at the body, looks at the symptoms, right? So the focus becomes zoomed in on the symptoms itself. So looks at the various symptoms that the patient presents and then classifies it according to whatever the physician has seen before. For example, if there is a disease, pluria is the disease that he talks about, which involves coughing and a lot of blood and things like that, right? So there are certain symptoms. Cough, for example, the blood that is visible, for example, these are all symptoms. So the physician looks at that, looks at the various symptoms and collates it. Okay, he looks at the disease and then says, okay, I have seen this symptom before, and then comes to a classificatory kind of a diagnosis. And in the 18th century, in the 19th century onwards, he says that this kind of a gaze, there's a certain change in the way that the physician look, the clinician's gaze. What this from 19th century onwards, the focus is not on the visible symptoms itself. Right, in 18th century, it's on the symptoms that are very apparently on the surface. But from the 19th century onwards, what he calls is the age of Bichat, the focus is on what lies beneath the surface. So that is briefly, broadly known as the anatomo-clinical gaze. So then he also briefly talks about how during this period the clinic as the space itself is invented. So that's broadly the ideas that we'll be looking at. So firstly, what is the gaze? Right. So according to Foucault, the gaze is not just something to do with visibility, right? It's not just the patient looking at the doctor looking at the patient, but rather it is also constructed by the knowledge that is surrounding it. So that's what he says. This act of seeing and the act of saying, they are simultaneous, right? So the gaze is not just visual, but rather it also is something that says. It's also something that structures the medical knowledge that surrounds it. So in that sense, it's not just something to do with vision, but something to do with the discourse of medicine itself. Right. So as soon as the doctor sees something, the doctor says what he sees as well. So doctor is also involved in the structuring of the medical science itself. Right. So the unimpeded empire of the gaze structures medical knowledge itself. And like I mentioned earlier, the gaze establishes the individual. That is, the focus is on the body of the individual, right? And at the same time, it is making a rational language. By language, we don't just mean the verbal language, but as we know, the system of knowledge. right? So like how language has syntax and grammar, there is a certain knowledge which has various parts, right? So the medical knowledge itself becomes a discourse, and that is created around this time. So that is what he means by the gaze, which is constructed both visually as well as linguistically. Now, this is the point that I think is something that we should look at majorly. That is how the discourse changed before 18th century, like I mentioned earlier, uh, the rather than the clinic, right? The doctor would come to your home, or the clinician, not I shouldn't say clinician, but the physician would come to your home. So the space is the home. The disease is located within the home, right? But after 18th century, what happens is that there evolves a space known as the clinic, right? So what happens in this clinic? Um, Firstly, the language of the doctor itself changes. So this is something that he mentions in the preface towards the end. He says, rather than what is the matter with you, the language becomes where does it hurt, right? So what happens here? One thing by by saying where does it hurt, the object itself becomes the body, yes, and the object itself becomes the disease. So the idea is to find the cause of the disease. Causality becomes central, right? So that is the one thing that we can know about it. And secondly, what is the issue with the question, what where does it hurt? Um, if we think about what is the matter with you, isn't it? This is not something that Foucault says directly, but to me, that's how I interpret it. It is more holistic, right? It's about the experience of the patient. That's why we talk about illness experience these days, right? It's about the experience of the patient. But when we ask about where does it hurt, it goes directly to the cause of the issue, and it goes directly to the disease, right? So here, what happens is that the relationship between the signifier and the signified is redistributed. So what happens is that the focus becomes on the symptoms that signify the disease, right? So that is the presumption that is happening over there. Now, before we come here, I want us to go and look at this one particular
Not
scene.
very.
One second, I'll just change the screen. So we'll be looking at a small scene from this 2001 movie known as Wit, starring Emma Thompson. So it's based on a play. Now, the movie is about the experience of a cancer patient. And she was a literature professor, an expert on John Donne. Now, this particular movie focuses on her experience of being a cancer patient and the way she's treated by the medical community around her. Right. Before we proceed further, does anybody have something to say about what we just saw, the small scene that we just watched?
I think it also has to do with the grand rounds as a custom, as a sort of
Hmm.
ritual,
Hmm.
which sort of takes patient for granted, maybe.
Hmm. Hmm.
Like, although they did acknowledge that patient was cooperative by the end and
Hmm.
there was a not mutual agreement, but that
Hmm.
mutual agreement is usually perceived in a very granted way, given
Hmm.
that they are terminal patients and
Hmm.
are subjects or objects of study.
Hmm.
And the whole uh, operation of touching and
Hmm.
it was shown in a very raw
Hmm.
style in that particular
Yeah.
scene. The
Hmm.
whole act of touching and pressing that ovarian uh,
Hmm.
region,
Hmm.
it was a bit harsh and uh, it literally touches the audience also in a way, maybe. From my reading, if I have to connect it, there was this part where Foucault says that the end of the
Yeah.
seeing and what is that part? Seeing and gazing. Yeah,
Seeing and
seeing
knowing.
and
Yeah. Hmm.
yeah. So in the end of that particular chapter, I think Foucault mentioned something like gaze and
The
glance.
glance. Yeah. Hmm.
Yeah, so that particular gaze transforms into glance when uh, through the medium of touch, through the act of
Hmm.
touch.
Hmm.
And I think it applies here in the way where With gaze, there comes a lot of noise, there comes a lot of
mm,
observation and stuff. But with glance, I think you just focus on that particular part, like you put it very aptly. Where does it hurt? And
mm,
people are only focused on the place where it
mm,
hurts. People
mm.
are not even concerned about the hair loss, which was very prominently visible.
Exactly.
So these are some of the points which I observed.
Yeah. Great. Anything else? Jilu, Aryan,
Uh,
Subhi.
to add it further, they are very dismissive of
Hmm.
conditions like depression or how the
Hmm.
patient is feeling
Hmm.
about herself due to the hair loss.
Hmm.
And also the body, the whole focus is on body, and it is very much treated as an object. It is
Hmm.
a parallel to the film which was made in India, like Munna Bhai MBBS, where the
Hmm.
patient Anand was constantly treated as a subject.
Hmm.
Nobody was caring about what his name is.
Hmm.
Similarly, they are very much concerned about the symptoms, the dosages, the cycles, and everything,
Hmm.
but not about the patient's identity, patient's
Hmm.
mental condition. Like we are not told that who she is, what she does. In the
Hmm.
end, we know that she was a professor, and she herself reflects back and tells that now she is the subject, she is
Hmm.
being taught in
Hmm.
a way.
Hmm.
So
Yeah.
this is a fault of, in a way, institutionalization of medicine, where
Hmm.
the whole focus is on body
Hmm.
and the symptoms, ways to cure it, and the
Hmm.
patient itself gets transformed into a kind of object to be treated,
Hmm.
to be managed.
Yeah, exactly right.
That's it.
So that was very, very accurate. So that is something that, yeah, Aryan wants to say something, right?
Yeah,
Go
this
ahead.
reminds me of that Black Mirror episode, if you guys have seen that one.
Yeah,
Black
season,
Museum.
later season, first episode, or which one?
There is this, I think that is season four, Black Museum.
Mm-hmm.
So in that episode, the thing is, there is this patient
Hmm.
in the institute called Saint Junipers.
Hmm.
So in that institute, what they do, they figure out a way. They
Hmm.
create an implant where the doctor can feel
Hmm.
what the patient is feeling. So this
Hmm.
idea of where does it hurt, right? The
Yeah.
doctor does
Yeah.
not even need to engage in a conversation with the patient. The doctor has
Hmm.
that implant and they put a weird sort of helmet on the patient's
Hmm.
head and the doctor can just feel what the patient
Hmm.
is feeling.
Hmm.
So in a way, the doctor has a better idea of what the where the pain is.
Hmm.
But
Hmm.
the entire engagement, the entire dialogue with the patient ends because there is no need for dialogue. There is no need to ask the patient how they are
Hmm.
anymore. Doctor will just
Hmm.
feel it by themselves. Yeah,
Yeah.
so it reminded
And
me of that.
yeah, it's very efficient, right? You don't have to
Yeah,
waste time talking to the patient, and the focus is on, okay, in that episode also, he cures them very quickly once he figures out where the pain is
yeah,
located, right? Yeah, exactly. So with this focus on pain, see, here also the doctor's gaze is directed not towards the concrete body, but towards intervals in nature, the signs that differentiate one disease from another, the true from the false. So the focus is, so the doctor learns to filter out. So in that case, the doctor becomes a sieve where the different, so that is the basis of differential diagnosis, right? If we watch House, we know that, right? So you make a chart. If this is not this, what else could it be? What are the symptoms? So the doctor, in that sense, just focuses on the, like Subhi mentioned, focuses on the particularity of the disease and not about the entire condition of the illness itself, right? So this is something that we see in the chapter 7 as well. So what happens is a certain effacement of the patient. This is kind of ironic, right? Earlier, Foucault says that the gaze constructs the individual, he becomes an individual. But at the same time, because of this very gaze, what happens is that the individual gets subtracted. So what comes to the focus is the particular qualities of the disease. So like Subhi mentioned, rather than the name of the patient becomes a case, right? So that's patient number 123, whatever, right? And rather than the patient itself, the disease becomes the primary object of study. So, like we saw in the scene earlier, they are not concerned about. when they talk about depression, oh, it's just there is no way that depression could happen. Or if the patient is vomiting, oh, that's just a routine side effect. And they don't even consider the side effect of hair loss itself, which is something that could be, it's a very life-changing event, right? Something such as undergoing chemotherapy, but that is not, they're entirely dismissing of that idea itself. So instead of the individual, what comes into focus is the disease and the particularities of that very disease. Now, why does this happen? It happens because, like I said earlier, um, before 18th and 19th century, the disease was located within the family, within the household. But with the invention of the clinic, what happens is that there is a neutral domain in which the disease becomes a singular event. It becomes a pathological fact where the doctor comes across the same thing again and again. There are certain repetitions. So they have seen the various, permutations and combinations of the disease that the doctor comes across, and the patient no longer becomes unique. Right? The patient becomes similar to, oh, this is very similar to a case that I saw earlier. Right? So in this case, the patient is cancelled out, is effaced, and there is no unique characteristic itself. Right? So the variations are cancelled out, and in this repeating event, in the neutral space of the clinic or the hospital, there is a collective subject that emerges. Now, in this process, disease in that sense is created as an object of study through this objectification of the patient experiences. Now, I'll just show one more. Um, so this is a point that Foucault just mentions. This is one line, but it's one line that stood out to me all the same. So I just wanted to share that. So that was a funnier version of things, but that I think pairs very well with this idea of the medical esotericism, right? So basically, what happens with this construction of this language and knowledge is that it's only accessible to certain people and not really visible or understood by others. Right. So in this process, like we saw in the clip in which the patient herself is excluded from this medical process, and only a certain, a very few number of people have access to the truth, so to speak. Right. So what this leads to, this is another point that I wanted to even briefly touch. So even though the focus shifts from the apparently visible to the invisible, that is, the focus shifts from the visible symptoms to the act of actually looking into the body, still some information remains elusive, right? So that's the problem with things being structured by language. Whatever is expressible is the only thing that is accessible to us, right? There is this precarious balance, and because certain things cannot be expressed by language, we cannot ever know what is not expressed. Um, so, like I mentioned earlier, in the 18th century, there was the focus on classificatory medicine, but by 19th century, Foucault calls it the age of Bichat. So, what happens is that Bichat was a French scientist, and he was known for using cadavers in knowing more about what happens within the body, right? So with this, what this comes with the introduction of the pathological anatomy. So now disease is no longer an essence. Disease is no longer something that is mysterious, but rather the disease can be located and pointed at within the tissues itself. So when we open up the body, what was previously invisible to us is suddenly rendered visible. So what happens is that death is no longer a mystery. Death becomes the object of study. So this is a certain penetrating gaze that through the dissection of corpses, we suddenly have an access to things that we didn't have access to before, right? So rather than life itself, medical science becomes concentrated on death, right? Death is what we are looking at. It's mortality that becomes the center of medical knowledge. So that was briefly what the preface and chapter 7 was about. So this is very evident in the last paragraph of chapter 7, right? He says that clinical experience is a new space opening about it. Like we mentioned earlier, it's a neutral space, the tangible space of the body, which at the same time is that opaque mass in which secrets and mystery of origins lie hidden. So instead of symptoms, instead of the medicine of symptoms, we are suddenly looking at, not suddenly, gradually looking at causes, right? The site of the disease. So that is where pathological anatomy comes into being. So that is what he calls as the age of Bishop. So before I end, I just wanted to briefly talk about something else that he mentions in chapter 7. So in true Foucault fashion, or whatever I could understand of it, he goes through the various ages, right? So he compares various medical philosophers, and then he talks about the limitations of the gaze, so to speak. So at first, the gaze was constituted of the alphabet. That is, people thought of symptoms as analogous to the alphabet and diseases analogous to discourse. But Foucault says that that assumes that diseases are very limited in variety, and it's very limited. And the second one was that he criticizes the philosophy that tries to just name the disease and it ends at that. He says that the naming the disease is at the end arbitrary, and you cannot reduce a disease to a name. And in 19th century, which is what we just talked about, the focus is no longer just on the visible symptoms. That is, it's no longer like a gardener looking at the garden and finding out what is wrong, but rather it is more deeper than that. It's all about the chemical processes that happen beneath the surface. It's all about, penetrating the actual body and seeing what is going on pathologically, right? And it's about distilling the relevant information from the irrelevant ones. And the doctor becomes, in that sense, an agent of truth. So here he also brings in the idea of the doctor as an artist, right? He compares it to an aesthetic art. The idea of consult a patient consulting a doctor. He talks about it as if a good doctor would be sagacious, would be very attentive, would be precise, and it comes with a lot of skill and as well as a lot of patience. So we know that there are some doctors that we like going to because we there is something instinctive about the way that they practice medicine. Right. So in that sense, he draws a parallel between the doctor and an artist. And this is the point that Tyagaraja mentioned. He also says that with 18th and 19th century, uh, there's a shift from the medical gaze to the medical glance. And he says that it's very gradual, and the gaze is gradually replaced by the glance. So the gaze would be open, right? It would be like, what are you, how are you feeling? Or, what is the matter with you? Things like that. It's very open. It wants to know what is going on. But whereas the glance is very short, it's very rapid. Like Tyagaraja mentioned, and like we mentioned in the Wit, the scene from Wit, it's like a sharp poke, right? It's very decisive, it's very sharp, and it knows just where to poke, right? And there is where to poke, and there is a certain violence that is involved in this glance as well. So this is also, we can draw a parallel to this and the idea of a family doctor and going to a very busy corporate kind of a hospital, right? You don't really have the doctors, you don't really have the time to talk to the patient or get to know them or understand their illness condition. Rather, it's about the turnover, right? How many patients can they see, and how many. It's about how much you can deliver within a certain amount of time. So with that, it was a very, very brief look into both the preface as well as chapter 7 of The Birth of the Clinic. I have one more scene that I'd like us to look at. It's a very short scene, but it struck out to me because the doctor doesn't even consider the idea of what could she possibly be scared of. We know that she was about to ask about mortality. Are people worried about, are apprehensive about the death that they are about to experience? And it doesn't even occur to the doctor here because he sees the tumor as something that is fascinating to be studied, right? He talks about the tumor as if it's a wonder, right? It's very advanced, it's proliferating and things like that. And it doesn't take into account what the patient could possibly be going through and the fear of death, which is a very, very basic and fundamental thing that drives us at the end of the day.
Like in the scene, why did he ask such an off-putting question like who is the president of United States?
I think because he was questioning her, senses. Are you really?
Sanity.
Yeah.
Okay.
Annie, with the two images which you had shown, right? Two clips which you had shown, what I could sense as an audience was a kind of estrangement. Okay, so basically, not going to the theoretical part in which you were trying to explain, but then the basic idea which you were trying to foreground was the invisible realities, right? Like what the patient has to face. So in the first case, you can see a cancer patient. You know that when you are affected by cancer, uh, the person who is affected by cancer is also trying to defend herself from the disease. And the doctors who come to her, um, they are also in a state of uh, defending themselves. They are not having an intimate conversation. So you, when both are being estranged, both are trying to have this is the basic idea where both of them are trying to defend themselves. Okay, if you are trying to understand from the perspective of the patient as well as from the doctor. So this is where we fail to have intimate conversations. And that intimate conversations is the basic idea which is being lacking in the first case. And that is where uh, the doctors are not able to feel what the patient is feeling, as well as the patient um, the patient is also trying to figure out what she is trying to do with the disease. I mean, even though she is part of the disease, she feels estranged with the disease. So she's rather, yeah, that's what I felt from the first clip. And then coming to the second clip, which is from Grey's Anatomy, it basically sees how, again, in a sense of estrangement, right? These people, the medical people, they only try to see the symptoms. Like, for example, if you take a CT scan, what are the basic idea of uh, the person, the symptoms that the person undergoes? I think it was being mentioned as autoimmune disease, something, and then the clinical result. That is what their only focus is about. Whereas um, for the patient, it is more or less in understanding what. Am I deviating from the
No, no, it makes
from
sense.
the way?
For the patient,
Oh,
they're being told that they can live, right? That's a
yeah.
very, yeah.
So, like in the second case in Grey's Anatomy, what you can see is that they are just reading out the things. Okay, they are not seeing the whole picture. Basic idea is about the estrangement that is being uh, invisible through the reality of life. That is where I guess these discussions are playing an important role. So, I mean, when we are talking about medical gaze, how medicine has dominated our imagination, basically, we are talking about this estrangement that has happened within the medical field, as well as from the objective reality to the subjective reality of the patient.
Yeah.
So, yeah, that is what it's just the way of deciphering from the clips. Okay, it is not based on the theoretical explanation. From gaze to glance, I haven't seen.
Yeah,
So
yeah.
that is,
It
yeah,
reminds
that.
me of, please go ahead.
No, no, no. Basically, he speaks about how medical discourse has been shaped throughout the centuries, right? Right from the 18th century towards the 19th century. So in that case, in the 18th century, you could see. I have read only few pages of Birth of the Clinic. Um, but in the first cases, we see that it was more descriptive. Then it was becoming more oriented only to the specific facts. So this is how medical discourse has evolved. That is one way of um what Foucault was trying to say, how medical discourse has evolved. Yeah.
Like adding to what Jilu said about facts right now, there is a particular line in this text itself, in the Seeing and Knowing chapter, where Foucault writes that art of describing facts is the supreme art in medicine. Everything else pales before it. So, while I read that particular sentence, immediately a question popped in my mind like, can human experiences go beyond such facts? So, so that is something from a very humanist perspective that we are more interested in. We are not interested in such facts, such words, or jargons, or esotericism, but rather we are more interested in the subjective experiences of these patients, right? And and that also proves to be more important for humanity, medical humanities as a field in itself. Another point is that about the Gray's anatomy clip again, is there was a lot of words which came in together in a very short span of scene. So it was almost like bombarding you with lot of signifiers. There is surplus of signifiers, and patient with all that overload of information, either there is scarcity of information or either there is an abundance of information, and either ways patient has absolutely no clue what to do with it. And uh, like in again, from taking a piece from chapter, there is a particular place where Foucault writes that Moliere, a guy who had his doctors who spoke in Latin. So he says that it was simply a matter of not being understood at that point because they are talking in Latin at that point. But it was something about preserving the level of linguistic formulation for the corporate privileges of this particular medicine profession. So I think that still prevails even now, after all the centuries ahead in 21st century also. Preservation of that corporate privileges through the medium of language is still at high. So that's there.
Yeah, so my father was underwent a certain illness around 2 years back, right? So it was quite serious. So what happened was that we went to a hospital. It was a pretty good hospital, and the doctors are very knowledgeable, whatever. So, but nothing was explained to us unless you know somebody in the medical fraternity, right, within your family or whatever. Unless you have an in into their language, you are simply a patient and you are told, okay, you have to go here, the bill section is here, you can go here, pay it, bring the slip back, go here, whatever. Right. But the doctors do not really take their time to explain what is happening to the body, why this happens the way it is, what is the next course of step, whatever. And it's only when we changed hospitals that we were able to experience that sort of a treatment. Now, that is because we knew somebody in that hospital. Right. So maybe if we did not have access to that sort of access to the Latin that they were speaking in that sense, we wouldn't know it. Right. We would still be the outsiders who would just be clients of a certain product that they are selling, and just it would just be a series of direction. Go here, get this scan, get this done, come back, pay the bill. Right. So that certain sense of we are always outsiders when it comes to something as important as medicine, right? Something that is literally the difference between life and death. So that's something that you only, even during COVID, right? We knew that there is a lot of red tape for a lot of people that simply doesn't exist for people who are already in that privileged bubble. So yeah, that was quite true.
Like, talking about your experience, even if they have spoken in a very
Mm,
comprehensive language to you and your family,
mm,
we at the receiving end might not have been in the state of mind to understand it. Like,
mm,
even if you are talking in proper grammatically sound English in a very slow and composed manner, your mind is in panic. It is absolute in defense mode and it doesn't know what to do, and everything sounds hazy to you. So at that those kind of moments, I think uh, it always feels too much to ask at some point that should doctors be more psychologically well equipped to talk to patients. And in those cases, right now medical humanities is a very expanding field. Like clinic, like how Foucault says clinic is in two domains. One is in hospital domains and one is teaching domain. Of course, he talks about medical teaching and all. But if at all we bring in health humanities to pedagogy of our higher education institutes, right? Uh, what role do teachers have? What role do professors or academicians have in communicating with students about mental health issues or even any sort of health issues for that matter? How much psychologically trained should we be? I mean, teachers, there is teacher training courses for all school uh, instructors. But are there teacher training courses for college faculties? Not really. I don't think so. And with rising cases of suicide and all sort of clinical depression that many students face because of stress and whatsoever reasons, and also other so many health disorders, and sometimes like these autoimmune disorders, or let's not even get to the autoimmune disorder as such. Let's take hair fall, which is kind of an autoimmune disorder. uh, Almost every one of us would face hair fall doing PhD. But and it also gets to you at some point, right? So uh, and people say do not get stressed, you will get hair fall, and then you get hair fall and you are getting stressed, and there's a vicious cycle. But how can you not be stressed, because you have to do this reading, you have to indulge in this particular meeting, and then you have to make a publication later on. So there are things which lies ahead in front of us. So who guides us in this process, be it teachers or doctors? Like Foucault compares doctors to artists. Let's compare doctors to even teachers, because at some point they even teach the interns, right? So teaching is almost a very omni uh, potent profession. Like it's almost everywhere, and uh, it just made me think like how much psychologically trained uh, we are, or how much importance do we give for such training in teaching field or clinical field.
Yeah, for us, the solution would be just to remove the ceiling fan. That's what. Subhi, would you do you have anything else to share? Some final thoughts?
For now, since I haven't read the text, I like the session, and that is something I really miss and I enjoy also. So thanks to all of you for today. Like I haven't read the text, so I don't have many things to contribute.
Yeah, yeah, it's okay. Officially welcome to the group. I think, Thiyagaraj will add your number to the group, and Jilu, I'll add you as well.
Yeah, what Thiyagaraj, when he was discussing about the psychology of it, that right, and there is this essay by Foucault. I think it is the creation of the dangerous individual. So in that essay, he is also talking about the post-enlightenment period and how there was a significant change in psychology as a discipline, how it emerged. And I think in that discipline, it was the opposite. The focus went from the the usually it is in the realm of judiciary, they're talking about how certain people who would commit very heinous crimes,
Mm.
they would be sentenced on the basis of their crime.
Mm.
This person has killed the other person, so the person should be sentenced. It was very clear like that.
Mm.
So the focus was on the act, right? Like post enlightenment, the focus is on the disease. Where does it hurt?
Mm.
There, pre enlightenment, the focus is on the act. What did you do?
Yeah.
But post enlightenment, the focus shifts on the mentality of the individual who has committed the crime.
The soul,
So I think,
right? Yeah. Mm.
yeah. So I think there, when we are talking about psychology and mental health, I think there has been the difference in a sort of a what is the word? A reversal there.
Mm.
That the focus in terms of what the physical pain has gone
Mm.
from this like everything that Annie explained to where does it hurt. But in terms of
Mm.
mental health, in terms of psychology particularly,
Mm.
like Foucault writes in this essay, The Creation of Dangerous Individuals, I think it is called, to that the focus has shifted to the question of who are you and why did you do this. And the
Mm.
judiciary would oftentimes come in find themselves in these situations where they are not able to figure out what should we sentence this person
Mm.
and how rigorous the punishment should be,
Mm.
because they'll try to look at the individual from a very naturalistic point of view. Where was the person born, why, what was
Mm.
the motivation, and all this. So
Mm.
I think that was interesting to me after reading this, because I had read that essay before
Mm.
I went through the highlights, and the essay that Annie had shared. I think
Mm.
that was interesting. A good
That's true.
comparison between these.
Yeah. So, in Discipline and Punish also, I think the first chapter, it talks about same thing, how the focus is on the soul of the individual, and more importantly, the causative factor. Why did he do what he did? And the point was to reform the individual, right? You send him to prison, you teach him how to restructure his action, and the same thing here. You go to the hospital, you find out where it hurts, and you try to cure that particular thing and bring back to the normal, right? There is a normative, then that's actually, I didn't think of that. That's very accurate.
So, yeah, but I think I should have asked this question at the very beginning. Uh, Given my layman's understanding of Foucault so far, we all know that medical gaze or clinical gaze, as synonymously used often, is treated as something very uh, uh, bad. It's
Mm.
not so good. It's not so great, and we should get out of the clinical gaze or medical gaze, and that's a very layman understanding, right? So you should give agency to the patient, whereas medical gaze robs the patient out of it. So that's there. But after reading this particular text, I feel that gaze is not as bad as we have understood it to be. Whereas he talks about gaze in a very historical lens, that how it has been
Mm.
transforming itself, how gaze has been transgressing senses. Like first, it is not just about visibility, but it is also about hearing. It is also about speaking, and gaze transform itself in multiple space sensorialities. And finally, he also says gaze transforms into glance
Mm.
at current medical scenario. And I find glance to be more problematic
Mm. Mm.
than gaze at all.
Mm.
So I have
Mm.
never seen any, at least popular scholarship, discussing about glance, medical glance.
Mm. Mm.
People only dismiss medical gaze or counter medical
Mm.
gaze. I mean, I
Mm.
just wanted to ask Annie or anyone here, like, what is the reason that we are so critical of medical gaze and we never really discussed about medical glance?
I'm coming across the word for the first time after reading this, similar to you. And I think maybe we think that gaze is a bad thing because we know about male gaze. That's what we think of. So we
Right,
clearly make a connection there, and then, yeah,
right.
we try to bring it up from that. From whatever I read, all I know is that he later came to regret his use of the word gaze. That's it. That's all I know. But he's not the first one to talk about it also. I think he takes quote from Sartre. I don't know what Sartre said, but I think he continues whatever Sartre said when he's talking about
Who is that, a
gaze.
scholar?
Jean-Paul Sartre, the
John Satra.
existential
Okay, yeah,
philosopher.
yeah, yeah. Yeah, yeah.
So I think it was response to whatever Sakura was talking about. So that's why I said we can't really talk about this text without knowing about what comes before and after. So, but then
Hmm.
we don't really have the time to do that also with this limited glance. So
Yeah, at
maybe
least,
we just glance through the text. So yeah.
yeah. Try it. Good one. So yeah, it was a very fruitful discussion. At least good to begin with, and this is
Yeah.
what I wanted, like to ease my reading experience of Foucault. So thanks to you, Annie. Let's
Yeah,
see
thank
you
you,
guys
Annie, for
next
the
week.
wonderful
Thank you,
presentation.
Annie. It was very comprehensive. I got all of it. That is what I think.
I don't know about that, but thank you. Thank you. Thanks a lot for
Okay.
being here, guys.
Thank you so much.